Some of you might know, but most won't, at least from the questions I get. What happens after medical school? Can you just go out and practice and be a doctor? Like some medical students will tell their family, I'm a doctor, and they are. But can they legally practice medicine? The answer is no. After medical school, which is in the United States and North America in general, is 4 years after a bachelor degree. So in total, 8 years of education to finish medical school. But in some countries in Europe, in the Middle East, and some other part of the world, it ranges between 6 to 7 years, and it's from high school. So you don't in those countries you don't need to have a bachelor degree. You just enter medical school. That is 6 or 7 years right after right after high school. So you finish the medical school, and some countries, those countries with longer years, will incorporate the last year as an internship, which you do bulk of rotations in major departments, like 6 to 8 weeks in obstetric, OBGYN, and similar in internal medicine, similar in surgery, psychiatry. It varies between country to another, but you will be exposed to major departments, but not the uncommon one, like for example pathology. That you will have a month or two of doing elective, but then you will not have enough exposure during medical school. You either have to love it just because you somehow connected from your history through a family, through an incident, through a movie, through something that happened in your life, or a short exposure. Then you finish that intern year in those countries, or in the United States, you finish the 4 year and you apply for a residency program. It is as challenging to apply and be accepted in a residency program as it is for medical school. So you finish medical school, in the last 2 years, you start kind of working on research, publication toward the department or the residency you want to go in, and then you do a rotation with them, you do an elective with them, meaning you go outside of university and you submit and kind of a visiting medical student or shadowing medical student. There are many names for it. So you can get exposed to other people, especially the programs that you want to apply into, because you want them to get to know you, and you better be good. And then you obviously apply, you enter a process called a match. There's a whole huge system in the United States. I'll focus on the United States for now. And then you do the interviews with different programs. They rank you, you rank them, and then there's a match day where all the results become kind of they announce it all at the same time. So each student will get an envelope, and they do usually some sort of ceremony or a match day kind of celebration. Everyone will open the envelope, and you'll see a lot of happy faces, some sad faces, because if you get the program you wanted, then you're very happy. If you did not get the program, your top three, then you're not as happy. But then you're really sad if you did not get matched, because you have to then wait until the year after, or see if there's a program that failed to fill their position and get into that spot. But it becomes kind of not having a house or being homeless, kind of the idea of that. So that what happens, and then you join a residency program. For example, I'm an OBGYN. I applied for OBGYN, got accepted in OBGYN, did 5 years of OBGYN in Canada, because in the United States it's only 4 years. It varies, I told you. And you, depending on the country or the state or the university, each program, they have general criteria across the nation, but then each program will have like certain rotations, like 3 months in gyne-oncology, infertility, obstetric. Half of it goes obstetric usually, and half goes gynecology. Last year you become a chief resident, which was you have more autonomy. Everyone knows you. You get to operate more, and then once you're done with that, then you can practice medicine. Not after medical school. After medical school, your MD degree will be useless if you don't get into a residency program. You cannot practice medicine with it. You cannot get licensed or anything. After residency program, on the other hand, you can just stop by finishing residency program and being a generalist. Like you finish the 4 or 5 years OBGYN and you become a general obstetric and gynecologist. You do a bit of here, a bit of this, a bit of that, mainly OB, some gynecology, some mix, so depending on the physician's preference. Some will like to do a little less in this and a little more of that. Most people start doing everything, and toward the end, they get tired of obstetric because of the call and the intensity. Then they switch into gynecology. But in general, in OBGYN, we don't have extensive enough training, in my humble opinion, to be an advanced gynecologist, just by nature, because the 4 years is not enough to learn everything. And it's really different. OB and gyne is two different things. And then each program and each resident will have a case log, which indicates the number of cases they did and how many deliveries, how many complicated deliveries with different names, how many hysterectomies open, which is like doing a big incision, versus minimally invasive, which is doing small incisions, how many certain procedures, all will be named, and they have to have a minimum of what ACOG, the American College of Obstetric and Gynecologists, is required. And if you will be surprised to see the number of cases for gynecological cases is very, very small compared to, let's say, general surgery. So, for example, to pass the residency program with adequate number of cases in the 4 years, you have to be doing a minimum of, I can't remember exactly, don't please quote me for this, but 15 to 20 hysterectomies open, 15 to 20 hysterectomies minimally invasive, small numbers. And could you imagine 4 years doing only 20? You could get lucky and do more, but most programs don't get lucky because how busy it is and how many programs out there. And you finish residency with that small amount of number of cases. Most of it was done by you being supervised by someone else, not even doing all the case. Some of it, sometimes, most times you do part of the case or half of the case maximum, and that's considered part of the number, the 15 or 20 hysterectomies. So you can just imagine, as a patient or as a person that is outside of medicine, the competency. Like, you can't help it, even if you're God himself. Like, you cannot graduate being good at that, confident, safe, efficient, uh, when you're doing only that number of cases as a requirement for you to be an OBGYN. So I feel bad for all the residency and for the residents and for the physicians and most importantly for the patients, because your surgery is done. Hopefully, you hope through the years they got enough kind of learn and error and have more cases under their belt to get enough numbers of hysterectomies to be safe to do your hysterectomy. But not what we see all the times. And I'm not being disrespectful to any general OBGYNs. It's just a fact. If you ask me, I did a lot of OB, but after a few years of not doing it, I don't feel comfortable even delivering a baby, which is a very simple thing to do, you think. So if you chose to get more training, to be specialized, then there are many programs. I'll mention some of them. There is family medicine, family planning, which you know the name, uh, uh, and then gyne oncologist like myself, which is dealing more with complex gynecology and gynecological malignancies, uterine cancer, ovarian cancer, cervical cancer, and that's usually 3 to 4 years of additional years of training as a fellow. They call it a fellowship. That's another match, another application, another challenge to be accepted, another few years of being slave to the system, another few years of not sleeping and long working hours. But it's worth it if this is what you want to do, because you have a vision of who you want to become as a surgeon and as a servant to your community. or as a person that wants to serve the community. Or you can be an infertility doctor, which dealing with like all the issues with infertility. They call it a reproductive endocrinologist. Endocrinology issues, imbalanced hormones. I'll mention some of it. Definitely, infertility is some of it. And then a urogynecologist, which is dealing with pelvic floor issues and surgeries and reconstruction. That's usually bladder issues, incontinence, and much more than that as well. But just for the sake of time, you could be a minimally invasive gynecologist, which is kind of this that I did a second fellowship after my gyne onc fellowship there. So I did two fellowships, and that's to do advanced gynecology through a minimally invasive techniques, through robotically or laparoscopically or single port or multiple port, it doesn't matter, but is how to achieve the same surgical result and outcome for the patient, with the least pain, the shorter hospital stay, the less bleeding, the faster healing, faster going back to work, faster being able to just be yourself again. So that's one of our new kind of fellowships, and it's very competitive. And we have it in my university. I'm a program director for that fellowship. It's called the Minimally Invasive Fellowship, and that's to train OBGYN residents that finish the residency and instead of working, chose to give another 2 years of their precious life to learn more, to be able to serve their community and patients better, safer, faster, more efficient, and deal with more complicated cases. Because all what I said about the number of hysterectomies you need to finish to be a general OBGYN, that doesn't include the complicated cases, guys. That doesn't include endometriosis, fibroids, pelvic prolapse, all the real complicated cases. That's all bundled in the 15 to 20 case. So you can really get to kind of understand really quickly the concept of general OBGYN not having enough experience, not because of anything wrong with the person or the practitioner. It's just the nature of our training. So just read about your surgeon, make sure they're qualified, make sure they are fellowship trained from a good program, make sure that they have enough numbers of cases. You can ask all those questions, and you have the right as a patient to ask all those questions. Unfortunately, like in the community, there is still 60% of hysterectomies are done open through a bigger incision. That shouldn't happen. That shouldn't happen because, for example, in my practice, we do for benign gynecology, no matter what the pathology is, zero open, zero open. And I'm proud of that. And I'm proud of my fellows doing that with me. And I'm proud of teaching that. And I'm proud of going to conferences and teaching it not only to my fellows, but nationally and internationally, because my first goal and all my colleagues' goal is best care for our patients. And patients don't know sometimes. So we have to be our patient's advocate. And that's the purpose of this video. Please don't take any negative out of this video. Just it's purely educating our community, our patients, our population about simple issues like this that they don't teach in schools, they don't teach in TV or movies or anything like that, and you're kind of lacking that knowledge. So my job and our job is to educate you. So if you like what I said, I'm gonna post more videos specific to pathology, specific to training, specific to uh, care after surgery, and much more after this. And the purpose of my channel is this, but also is my life as a surgeon and a day-to-day kind of living, because that's also a question that I get to, I get a question that I get a lot from my friends, from people I meet. What do you do? How is the surgery? When do you operate? Because they see me as their friend and they never know what is my life looking like on a day-to-day basis. So I thought it's interesting. It's a new idea. I'm trying to explore it and see how it's gonna go. I hope you like it as well. And it's going to be a journey, and I'm excited about it. Ciao, ciao. See you later.